Recording in progress.
Hello, everybody. Happy New Year and welcome to this new webinar that is going to be very, very exciting. We apologize for all the problems and inconveniences that we have with the technological troubleshoot, but we have sorted this. Today we have we have the great pleasure to invite Professor Robert Fisher, who's going to give us a great talk about neuromodulation in epilepsy. Robert Fisher is the Maslah Saul Professor and Director of the Stanford Epilepsy Center and the EEG Lab. He has published about 240 peer-reviewed papers and 3 books. He has been named every year from 1996 to 2021 in Best Doctors in America. He received the Ambassador Award from the International League Against Epilepsy and American Epilepsy Society Service, an award and clinical research award. Dr. Fisher is the past director of the American Epilepsy Society. He has been editor-in-chief of Epilepsy and epilepsy.com. Dr. Fisher led projects to develop the ILAE classification of epilepsy and update of seizure type classification. His recent research is on new devices to detect and treat seizures. He leads the clinical trials on deep brain stimulation for epilepsy and on the next generation of heart rate sensing, vagus nerve stimulation devices. It's very honor for us to have such a renowned world speaker to give us her new research about neuromodulation. Thanks so much, Professor Fisher, for hosting this webinar. And also we apologize for this time.
Oh, that's fine, thank you. Thank you for inviting me. And thank you to all of you for giving up some time on your weekend to come to the talk. We're going to talk about neuromodulation for epilepsy. And in the talk, I will use neuromodulation as a synonym for neurostimulation. I should start by telling you my disclosures. When the DBS thalamus treatment was approved, I became a consultant to Medtronic to do some teaching and training. And I was the principal investigator for the LivaNova, formerly Cyberonics, vagus nerve heart sensing trial. I'm not being paid for this talk. And then I have a variety of irrelevant disclosures to this talk, which you can see. So in the United States, there are 3 places where the nervous system is approved for stimulation for epilepsy, and then many more where stimulation has been tried, but where it's not officially approved, and those that are not approved don't have large controlled trials behind them. Those 3 places are the vagus nerve, the seizure focus itself with responsive neurostimulation, and the anterior nucleus of thalamus. And those are the 3 that I will talk about. I'll give you an overview of the efficacy and the side effects of each of them. I'll spend a bit more time on deep brain stimulation because it's the newest. And then I'll tell you a little bit about how we might decide to use one versus the other if we had a patient with refractory seizures. So let's start with vagus nerve stimulation, VNS. VNS had 2 definitive trials, controlled trials. The first, the EO3 trial, showed that active stimulation reduced seizures in a median of 37.5% versus 8% for the low-level stimulation. It couldn't be a true control because people can feel the stimulation in the neck, but high versus low. And then our government required a repeat confirmatory trial, which showed the statistics that you see there, also significant. It is interesting that all of the epilepsy neuromodulation methods improve over a matter of years. This is different, for example, for neurostimulation for tremor or for Parkinson's disease, where the improvement can be seen right in the operating room as soon as the stimulator is turned on. So we're dealing with different mechanisms here. But the vagus nerve stimulation, long-term efficacy, improved to about 50% or so over a matter of a couple of years. Only about 8% of people became seizure-free for 6 months or more. Now, the responder rate, the rate by which seizures are cut in half or better, is listed here for temporal seizures, extratemporal, and multiple types of seizures. Then you can see the vagus nerve stimulation trial in the real world called the PULSE trial, where in blue you're seeing the vagus nerve stimulator in addition to best medical practice or best medical therapy. And in red, the dotted line, you can see just the best medical therapy alone. So you see that addition of the vagus nerve stimulator helped. But I redrew the scale on a full scale of 100%. And as you can see, the improvement is significant, but it's not numerically very large. And this really brings up a point, even though I think there's probably, well, there is a larger degree of improvement with the intracranial modalities of stimulation, that neuromodulation is not a cure. It's a palliative therapy just to make things better. So it turns out the vagus nerve stimulator sits right next to the heart and can easily detect heart sensing. So the possibility is there for turning on the stimulation as soon as it senses an increase in heart rate of either 20, 30, 40, 50, 60, or 70%. You can see that in this chart. A seizure begins, the heart rate has increased from 80 to 96 beats per minute, and the stimulation turns on, terminating the seizure. Does that happen every time? No, definitely not. But there is some indication that adding the heart rate detection helps the seizure burden. You can see that in this slide where the top bar here is the breakdown before the heart rate sensing is added. These are people who had conventional VNSs that were replaced with a new generation heart sensing vagus. And you can see that a shift towards the more beneficial outcome, no seizures, 8%, 80 to 99% improvement, 27%, is higher in the lower bar than in the upper bar. Here's another study that similarly shows that 4 out of 11 patients who didn't respond well to regular VNS had greater than a 50% seizure reduction when the heart sensing VNS was added. There hasn't actually been a controlled comparison study, but what we can say is some people do improve over the usual stimulator when we add the heart sensing. And I should say that the heart sensing does everything that the other stimulator does. It runs on a cycle, and it also can be turned on by a magnet swipe, but additionally has the equivalent of an automatic magnet with a heart sensing. So that is the default device that I'm using now for vagus nerve stimulation. Adverse events from VNS are predominantly sensations in the throat. I can always tell when a vagus nerve stimulator turns on because I hear the change in the voice. Initially, some people cough or feel some discomfort or some tingling, but that generally disappears if you raise the current slowly and give it a little time to get used to it. There is one side effect that we didn't really predict, and that is worsening of obstructive sleep apnea, which can have, fortunately, in just a few cases, a vagus nerve stimulation, but it is something to watch for. Now, VNS has a, if I can call it, a beneficial side effect that wasn't really anticipated. There were some patients in the trial who said well, you know, my seizures are not all that much better, but I just feel a lot better. And that's because it was also treating depression in some individuals. So in the United States, it now also has an indication for treating depression. That does set it up a little bit above the other two neuromodulation modalities, because RNS seems to be neutral for depression, and DBS can sometimes, particularly in the initial stage, worsen depression. Let's move now to the number 2 neuromodulation, which is responsive neurostimulation. Here, we put a very clever little EEG machine and stimulator directly into the skull with wires connected either to 1 or 2 seizure foci in the brain. And right away, that means you need to know where the seizures are coming from. The device senses when a seizure occurs from the internal EEG, and then it delivers an electrical stimulation, which is programmable in its characteristics, even externally programmable via a radio paddle to try to stop the seizure. You see an example in this slide here of how that works. A seizure has started, it's detected, the stimulation occurs, and the seizure stops. Now, I've written down here in blue, but is this the mechanism of benefit? Why do I ask that? Well, this device will probably detect several thousand electrical seizure-like events in the brain. And this would be perhaps in a patient who would just be having a couple of seizures per week. So there are vastly more electrical seizures than there are clinical seizures. And the VNS will stimulate to attempt to interrupt those seizures. So it's quite possible that in addition to the individual effect that it has on a seizure, it's also having a more chronic neuromodulatory effect just from the frequent stimulations that it gives to the brain. And I think both of those are probably in play, responsive neurostimulation. Here is the slide that led to approval of this device, the double-blind phase. Implantation starts, and then stimulation begins, in the case of RNS, 2 months after implantation. Now, you will notice that there's an improvement of about 20% in seizure frequency even before the stimulator is turned on. And you're going to see that same thing in the DBS trial. So what's going on there? Is it placebo? Maybe. Is it what's been called a micro lesion effect, where just the passage of the wires through the tissue has caused small lesions that make a benefit? Or is it something much less interesting, which is just that people don't go into an invasive surgical trial when they're doing well. So they will wait for a point where they're doing badly, and therefore chances are the next time you take a measurement, it will be better just by fluctuation. That's called regression to the mean. I don't know what the answer is to that initial improvement, but we see it in all kinds of procedures, even pneumoencephalography in the old days. Well, what is important is when the stimulator is turned on here in the black line or in the dotted line with sham stimulation, then the curves begin to diverge and are significantly different. In the case of RNS, with about a 40% reduction in mean seizure count per month. Over time, as I said, it improves. So you see going out to 2 years here, the median percent in reduction of seizures gets better and better. 100% would be up here. And the responder rate, the percentage of people whose seizures are cut in half or better, also continues to improve. As we go into the real world, the rate of improvement turns out to be even better than in the clinical trials. ranging in the 70 to 80% range or so median reduction in seizure frequency. Slightly different for mesial temporal lobe epilepsy, which is this bar, and neocortical epilepsy. Remember, though, that you can only stimulate at most 2 seizure foci. All the patients want to be seizure-free so they can drive. 18% were seizure-free at last follow-up and 23% with RNS seizure-free for 6 months or longer. Other than local site infection, not brain infection, the side effects were predominantly those of seizures, and those might not actually have been caused by the stimulator, but just failure to treat. And you can look at the other list of less frequent side effects here. So now we move to the third and last modality that's approved, deep brain stimulation. You see an electrode with 4 contacts on the tip on each side. Do we have to implant bilaterally if there's unilateral temporal lobe epilepsy? Maybe not, but we did implant bilaterally in the clinical trial. So that's what we usually do. Now, going back historically on this, this is a autoradiography picture from a guinea pig brain by Mark Mirsky and James Farandelli when they were at Washington University, St. Louis. And it shows what parts of the brain light up when a guinea pig is made to have seizures with the GABA antagonist convulsant, pentylene tetrazole, PTZ, injected. And you can see that what white is most active are the mammillary bodies in the posterior hypothalamus and the anterior thalamus and the mammillothalamic tract that connects them. Then Mirsky and Farandelli showed that if you cut the mammillothalamic tract, you need much more PTZ to make the animal have a seizure. So Mirsky came to my lab, and we decided to see whether electrical stimulation could function as a reversible lesion for this system. And the answer was yes. Here we're stimulating the mammillary nuclei. You see a slow sweep speed of spikes in cortex produced by pentylene tetrazole. And when we give the stimulation, it interrupts the spiking and reduces the intensity of the seizures. Problem is the mammillary body is a difficult target. It's small. It's close to the circle of Willis. If you get hemorrhage in it, you might end up with a Wernicke's encephalopathy. So we went to the next place on the way station of the so-called circuit of Papes, which is the anterior nucleus of thalamus. Now, the circuit of Papes goes from hippocampus via the pharynx to the mammillary nucleus in posterior hypothalamus, then to the anterior nucleus of thalamus, then to the cingulate region, and via the cingulum bundle back to entorhinal cortex and hippocampus. So that is a network. That's a loop, which was described by Papes and later McLean as being involved in memory and emotion. But it also happens to incorporate the most seizure-prone regions of brain, namely the mesial temporal lobe and the mesial and anterior frontal lobes. So we thought this was a good circuit potentially to disrupt, to treat seizures. Now, why might it work? Particularly, why would it keep improving over years? And we are, this was a mystery for a while, but we are now learning several mechanisms that seem to work together to explain this. I won't go into them in detail because I don't have time, but they include increased neuronal markers of cells in hippocampus, brain-derived neurotrophic factor increasing, apoptosis being less severe, programmed cell death, neurofilament synthesis being enhanced, Autophagy, which is a neuroprotective process being increased by DBS, actually growing new neurons in the dentate gyrus and increasing extrasynaptic GABA delta receptor subunits. These are just some of the mechanisms that have been shown in animal models and may be in play. There are changes in receptors, there are changes in genes, there are changes in synapses, and there's new neuronal growth that occurs with DBS, and that all happens over time. Got to tell the patients to be patient. So we implant in the anterior nucleus. You can see the target right here. And then we stimulate. In the clinical trial, we stimulated with 5 volts. The newer device use milliamps. Constant current stimulation is a bit more physiological in case the resistance of the electrode changes. You want to deliver a set amount of current. If the resistance, impedance of the electrode is about 1,000 ohms, which would be typical, then 5 volts is equivalent to 5 milliamps. I wish we had started at 2 volts and worked our way up, because we had 2 patients where 5 volts actually triggered seizures on every cycle of stimulation, which was 6-minute cycles, although they responded to when we turned the stimulation down. And a lot of patients had chest paresthesias at the stimulation site. So we now start with 2 milliamps and work up to 5 milliamps. We use very brief pulses, 90 microseconds, not milliseconds, microseconds, and high frequency stimulation in the range of 100, 125, 145 hertz seems more effective than something below 50 hertz. It's a peculiarity that movement disorder stimulation is almost always done continuously at 1, 2, or 3 milliamps. Epilepsy stimulation is done intermittently, 1 minute on, 5 minutes off, or the vagus nerve stimulator trials with 30 seconds on, 5 minutes off. This was done originally to save battery life, and because we thought it might be easier on the nervous tissue that we were stimulating. But it really is a historical accident and a historical difference. And I do have some patients with DBS that seem to do better when we stimulate continuously. It does run the battery of the device down faster. This is the pivotal clinical trial result from the Sante trial, which stands for stimulation of the anterior nucleus of the thalamus for epilepsy. And it looks rather similar to the DBS trial. We had about 20% improvement just from sticking the electrodes in. And then when we turned the stimulator to 5 volts, the gray bar lower, things improved better than with the sham stimulation. And it really was sham, because unlike vagus nerve stimulation, patients don't feel DBS or RNS stimulation. They didn't know what group they were in. And this difference at 3 months, blinded, between a 40% median reduction in seizure frequency and a 14.5 was statistically significant. Now, this is what really convinced me it did something. When we turned the stimulation on in the placebo group, they didn't know which group they had been in before. They quickly came down to the same level of improvement as the group that had been stimulated all along. And that's not placebo, that's not a microlesion effect. That's a stimulation effect. So you can see that they continue to improve over many years. I was a little afraid that we were going to engender the phenomenon called kindling, by which repeated stimulation actually makes seizures. It's a laboratory model, but kindling requires that you stimulate in certain ways, certain patterns and sequences, and we're not doing that. So fortunately, we haven't seen kindling out to greater than 10 years of stimulation now. So who benefits from this? Short answer is simple partial seizures, which we now call focal aware seizures, did not improve. Complex partial focal impaired awareness seizures did improve, and focal to generalized seizures improved, but we had too few of them in the clinical trial to demonstrate that improvement by the time we had long-term studies. The improvement was evident. Now, there are two reasons that simple partial seizures might not have improved. One is that the stimulation of this network isn't actually stopping focal seizures, but is just stopping propagation through the network. I think there might be some truth to that. But the other reason is that we converted complex partial seizures, where patients forgot, to simple partial seizures that they were aware of. Maybe both of those are true. So I'm not going to talk about it too much, but there is also the issue of what types of patients benefit, not just what types of seizures, but what regions of the brain, which nucleus is best for stimulating those, and what if they've had prior epilepsy surgery or had a vagus nerve stimulator in place. So to answer my last question to myself first, it doesn't make any difference if a prior vagus nerve stimulator or prior epilepsy surgery didn't work. There's still the same benefit in that subgroup as there is in other groups. That does not mean that DBS is better than VNS, because no one's done the study in the other direction. Someone who didn't benefit from DBS then benefiting from VNS. That's not been done. But what we can say is that it's not a contraindication if someone has had past epilepsy surgery or vagus nerve stimulation. I was pleased to see that injuries were reduced. This may be consistent with blocking propagation through a seizure network. Even in the blinded phase, there were fewer seizure-related injuries. And the seizures that patients called their own most severe seizures, they may have crossed groups from complex partial to tonic-clonic and so on, but what they thought that were their worst seizures, those improved also in the blinded phase. And then by Liverpool Seizure Severity Scale, chronically, the measures were better for stimulation. How many were seizure-free? About 18% became seizure-free for at least 6 months. And although that's not even quite 1 out of 5, keep in mind that the median seizure frequency in this group at baseline was 20 seizures per month. So being seizure-free for 6 months, I think is something. When we did the trial, we thought just getting the electrode in the anterior nucleus was going to be a good job. But subsequently, we've learned that there's a substructure to the anterior nucleus, and that placement within the nucleus matters. In particular, you want to be at the termination of the mammillothalamic tract, which can be imaged by some special MRI studies, STIR or F-Gator or MP-RAGE. You can see at the yellow hour, this black stripe here, that is the mammillothalamic tract. Here you see it a little closer up. Don't be confused by this black stripe on the outside of the thalamus. That's the fornix coming in. It's not that we want to stimulate the mammillothalamic tract itself. That's the input to ANT. But its termination usually marks the place of origin of the anterior thalamic radiations, which exit the thalamus. And that's what we do want to stimulate. So if you're going to get into the DBS game, you want to sit down with your neuroradiologist ahead of time and arrange to get some high quality images that can show this tract in the thalamus, because the usual MRIs do not. And then you can get a post-implant MRI, because it is possible to get MRIs with the leads in, or you can get a post-op CT and fuse it with a pre-op MRI, and you can choose which of your 4 contacts is sitting best at the termination of the mammillothalamic tract. Here it would be this one, or maybe this one. So there were some adverse events of DBS. About 15% became depressed, and about 13% had what they considered worse memory problems. Somewhat embarrassingly, about 11% had an infection, but these were either at the chest side or the scalp. There were no brain infections, no meningitis in the trial. There are paresthesias in the chest because we typically make one of our cathodes be the contact in the thalamus, and then the anode is the chest. That gives a wide region of spread of the current. You can do bipolar, but then you have a pretty narrow zone of spread that may not encompass enough tissue in the ANT. However, the side effect can be chest paresthesias. There are a few cases of status epilepticus. There were asymptomatic hemorrhages, no symptomatic. There were some triggered seizures. And I wish we paid more attention to sleep because we're stimulating structures involved in generating sleep spindles, K complexes, et cetera. DBS does disrupt measurably the sleep cycle if you study it. But in my experience, almost nobody complains of sleep problems or sleepiness during the day. So I'm not sure how clinically significant that is. Now, for the depression and the memory problems, remember that I said a few minutes ago that the circuit of Papes mediates mood and memory. So perhaps it's not surprising that we affect that. But the bottom line message is that it improves if you turn the stimulation down, and then it is probably better. At least the mood is better, especially if you have good seizure control. So it's not a long-term kind of issue. However, in my patients, I'm not putting DBS electrodes in if somebody is suicidally depressed, severely depressed, because even a transient worsening could be a problem. But if they just have mild and treatable depression, which so many, probably half of refractory epilepsy patients have, then I don't consider that a full contraindication. With the newest devices of DBS, we can sense the local EEG, what's called the local field potential, the LFP, and see activity during a seizure. And you see this here. This is the left thalamus. These are depth electrodes in left amygdala and left anterior and posterior hippocampus. So the device has a sensor in it. Now, what good does that do? Well, it can perhaps enable us, this is all new, so I say perhaps, enable us to count seizures, to be a biomarker for seizures, much as the RNS is an excellent seizure detector and seizure counter. It might be able to tell us left versus right, whether you've got a left temporal or a right temporal seizure focus, and count left versus right. And then in a next generation device, they might be able to make this responsive stimulation on the basis of the detection of the field potential. So let's do a quick comparison, and then I'll tell you how I choose, and we'll be done. Median seizure reduction, VNS 38, RNS 33, 38, and 40. Long-term at 5 years, 55, 61, 65. I'm not sure that these numbers are statistically different. Probably not. But I think there is a difference in percentage of people who are seizure-free for a stretch, with RNS and DBS making people seizure-free for a higher percentage of cases. The VNS is predominantly voice changes, neck pain, cough, rare sleep apnea. RNS has implant site infection, site pain, more seizures, and the possibility that you've put the recording electrodes not over the seizure focus. DBS had the transient depression and memory problems that I mentioned, and you can actually provoke seizures if you start with too high a voltage or amperage. So as I say, we're not starting with 5 volts or 5 milliamps. SUDEP is probably the most important side effect, sudden unexpected death in epilepsy. There is reason to believe that all 3 of the neurostimulation modalities reduce the SUDEP rate. Among surgical candidates, it's very high, up to 9.3 per 1,000 patient years. Patients who are in an EMU for evaluation have SUDEP rates of 7.5. The neurostimulation rates are approximately 2, and people with epilepsy in general who are not refractory have SUDEP of 0.58 per 1,000 patient years. So this may be a life-saving benefit. You will see flowcharts in some articles purporting to indicate how you would decide whether to use VNS, RNS, or DBS. I don't actually find those useful because I don't think we have the information to accurately guide to one versus the other uniquely. A lot of the endpoints end up saying use VNS, RNS, or DBS. So what I do instead is I use a checklist. You'll make up your own if you get into this, but this is mine. A green check favors, and a red X argues against using that modality. If a patient doesn't want you touching their head, then it's got to be VNS. If the seizure focus location is unclear, then it shouldn't be RNS because you need to put the 1 or 2 wires over the region of the seizure focus. If it's going to be difficult to tell where the seizure focus is, then doing DBS or RNS, DBS or VNS versus RNS may save the patient an invasive workup or another epilepsy monitoring admission. In other words, DBS and RNS don't really require you to know very much about where the seizure focus is. RNS does require that. If you have a well-localized focus, but it's not resectable, say in motor cortex or a speech area, in my heart, I believe that putting a stimulator right on top of the focus is probably going to be more effective with RNS than modulating the network would be with DBS or VNS. If you want to use the implant, not just as a therapeutic device, but as a recorder, because say you're not sure whether the seizures are left temporal or right temporal, you can put the RNS in each hippocampus, and a year later you may see that 90% of the seizures come from the right temporal lobe. So you decide to take the stimulator device out and laser that right temporal lobe to try to cure the patient. It really is a very good recorder, and it's showing us things about rhythms of the epilepsy, not just menstrual cycle rhythms in women, but daily rhythms and weekly and monthly and even longer rhythms in both men and women. And we might be able to adjust our stimulation or medication dosing when we get to see those cycles. So it has real benefit as a recorder. I'm not sure how well DBS works for parietal or occipital seizures. It may be that another nucleus such as the pulvinar would be better for posterior stimulation. That is what we call an off-label unproven assumption. There's increasing evidence for centromedian nucleus to be better for the generalized and multifocal seizures in the Lennox-Gastaut cases. But so far, the only firm evidence we have is with ANT for partial seizures. A lot of people are working on other thalamic nuclei. Untreated severe depression, as I said, I would not use DBS. If they don't want to see the implant, the chest bulge, then it's RNS because it's built into the skull. And by the way, when you replace the RNS, you don't have to do brain surgery. It's sitting in a pan that's screwed into the skull. So you just cut the scalp take the old device out, unplug it, put the new plug in, put it into the brain pan, close the scalp. Very sensitive to voice changes. They're not going to want VNS. If they can't cooperate with programming, RNS is complicated. And then my view is maximal efficacy, approximately equivalent with RNS and DBS, but maximal safety would be with VNS because you don't have to deal with the brain or cranium at all. So the summary then is that neuromodulation is in its infancy, but it's already having a big impact. It used to be the case in many seizure conferences that we would end up saying, we can't help this person. That is rare now. Usually we are talking about what type of neuromodulation will we do, assuming that we can't do a resection, which would still be preferable because it might be curative. But we'll talk about neuromodulation when we can't resect and what type and where to put it. VNS, RNS, DBS have rather similar efficacies, although as I say, RNS and DBS are probably better for making people seizure-free when it happens. Side effects and operational factors differ. VNS is less invasive, but may irritate the voice or throat. RNS has a good safety profile, requires localizing the seizure focus or foci. RNS can record seizures. The latest DBS can also, but it only really records the power spectrum of the seizure. It doesn't record the actual EEG like RNS does. DBS does not require localization, may cause usually transient memory and mood problems. Consider individual factors for choosing which modality to use. There's no universal flow chart, but the main thing is to try some form of neuromodulation. Don't just let the patient seize without doing anything else. And it's probably much less important which form of neuromodulation you choose than that you just choose to try some neuromodulation if the patient is not doing well. That's all I have. Choose wisely, but most of all, choose. Professor Jiménez, shall we deal with some questions?
Thanks so much, Professor Fisher. Do you mind to stop sharing the screen so we can start with the questions? Thanks so much. Amazing talk, very interesting.
Sure.
And many questions from the audience. So I'm going to start with some. People, the audience is giving you some wishes and they're very excited about your talk. And one question we start is, how many channels of a seizure is needed for the RNS to switch on?
So the RNS will typically show you 4 channels. There are 4 contacts on each of the 2 RNS leads. So if you do bipolar with each, you'll get 2 channels, say in the left hippocampus, 2 channels in the right hippocampus, or you might do hippocampus on one side, cortex on the other. It's your choice. And then you do detection on all 4 of those channels. So whichever one shows the seizure, you give stimulation. If different channels detect different seizures, you can still stimulate and even adjust the parameters differently to respond to, say, the left hippocampal seizure versus the right hippocampal seizure, how you stimulate.
Okay, but RNS should be mainly considered, as you showed in the slide, for cortical seizure, maybe not for deep structural seizures like hippocampus or locus seizure, correct? So it should be mainly for cortical epilepsies.
No, I'm sorry I gave that impression. I did say that I thought that for cortical epilepsies, I think RNS might be better than DBS, but RNS is also good for hippocampal epilepsy, and most of the RNS is actually for temporal lobe seizures.
Okay, so now moving on to the next question is about the price. because I believe that if these RNS techniques are not so cheap. So one of the questions is, how much does the RNS cost average?
Yeah, so the cost of doing the whole workup and implantation and surgery and buying the device in the United States can be $100,000. The device can be from, I don't know the exact cost, doctors in the US don't know costs, but 25,000 to more than that for the device itself. But then you also have costs of finding where the seizure focus is. So you can imagine the cost of doing implanted electrodes to record where the seizures come from, and then surgical costs, the recovery costs. Once it is in place, there are clinic visits, which the neurologist does, not the neurosurgeon, to review the seizures and to see if any adjustments need to be made in the stimulation or the recording when the patient comes into clinic. And that's actually kind of fun. You can go online and see the patient's recorded seizures and say, oh, look, if we just stimulated here, maybe we could shut the seizure off faster.
Okay, so the workup is still ongoing. So after the patient is being implanted, they're still reviewing the seizures, and they can still changing accordingly according to the different seizures. They can still adjust the parameters and the stimulation site. That's
right. We don't turn the stimulation on in the operating room. We just turn the recording on. And then when they come in 2, 3, 4 weeks after surgery, we've let them heal. We look and we see what the seizures look like, and then we set the stimulation according to that. But as we go on, we learn more and more about their seizures, and we can make the stimulation even better.
Is there any, this is one of my questions, is there any type of seizure onset that it's getting better, like a fast activity, low voltage, or any seizure onset activity that is RNS is detecting mostly, or there's nothing yet assessed about this?
Are you asking about the detection aspect?
Yeah. Detection aspect.
Okay, so we get a little bit technical here, but I'll answer since you asked. The first method that we usually use is what's called line length. Imagine that you have the EEG tracing, and seizures, as you know, tend to present either with a lot of low voltage fast. It's not much amplitude, but there are a lot of them, so that makes a longer line, or it makes big spikes or rhythmical big evolving theta or delta activity. So either a lot of that wiggle or a lot of this will make the line longer. So that's the initial detection, because it doesn't depend upon really any characteristic of the seizure. After we see a few seizures, we usually can see that there's a lot of high power frequency activity in a certain frequency band. Like you all know, you look at a seizure, you see there's a lot of 5 hertz activity building up, or 5 to 7. So at that point, it's more effective, we've discovered, to switch from the line length to choose the frequency band that is elevated in the seizure and turn the stimulator on there.
Very, very interesting. And how you can detect the false negatives? How can you combine these? Because well, normally only during seizures do we have this sort of activity, but is there any chance that RNS can, by any mistake, switch the stimulation on and due to false detection on? No.
Yeah, it's a good question. Well, we see on the website, which if the patient uploads their seizures, which we ask them to do every day or every few days, because the device itself can't hold many, but the website can hold all their seizures if they upload them. We see if the stimulation came on, and we say, because we see the EEG around that time too, real EEG, we say there's no seizure there. That means that we need to increase the threshold for detection. Another possibility is the patient might say, I had 3 seizures on Tuesday, and we don't see anything that was detected. Then we would lower the threshold for detection.
Okay, very interesting. Very interesting. I guess at some point AI would make it work also. Artificial intelligence would do it.
The company that does this, NeuroPace, has already applied AI, I assume you mean artificial intelligence, machine intelligence, to the detection and to determining the best seizure parameters. And it's doing pretty well. The company is very helpful to the neurologists. They run all sorts of analytics because they have the data on their website, and they make suggestions about changes that we might make. And yes, they are using artificial intelligence now to do that.
Okay, thank you so much. Moving on for a couple of more questions, if that's all right for you. So
Sure.
there's another about the price.
Any other modality yet? It's all in RNS.
Yes, well, they like RNS maybe. So, well, we can move towards another price comparison. It's telling about DVS or RNS. Which one is cheaper?
They're about the same. They're about the same, I think.
Right now,
the only difference is with DBS, you might not have to do another admission or even an invasive admission to determine where to put the RNS leads. Because you're going to put them in anterior thalamus.
Yes, so it's the same price. Okay, so now we move to another modality, DVS. I have a query from Penelope Dragumi. She's asking if DVS could be used for electrical status epilepticus.
Yes, there are 4 or 5 papers that have used DBS in status epilepticus, and in some cases it was effective. It's interesting because right now we have a patient in our neurointensive care unit where next week we plan to do emergency centromedian stimulation of thalamus for widespread epileptic seizures that result from a neuroinflammatory condition. So yes, it can be helpful, but these are at a case report level.
Yes, I've also read these papers. It's also from fires, mainly from these conditions, infection.
That's right.
All right, and yes, I think it's median nucleus, I think also. They target the median, the
central median.
Yeah.
ANT, anterior nucleus, is best for seizures that start focally in the frontal or the temporal lobes. And I think central median nucleus is best for seizures that are very multifocal or generalized. And posterior seizures, I'm suspicious the pulvinar might be a good site.
Okay, thank you so much. And we have the last question. It's telling us, it's from Jose, and it's telling us, asking you, what is the best area for stimulation, brain stimulation, for treatment of epilepsy? The best area for stimulation.
Well, the best area is at the seizure focus, if you know it. Hippocampal stimulation is becoming popular because the hippocampus is, of course, the most common site for seizures in adults. A randomized large clinical trial is not completed yet, but there are strong advocates of putting electrodes into hippocampus and stimulating. If you have focal seizures in temporal or frontal lobe, I think the anterior nucleus is the best place to stimulate. And if you have multiple sites all over the brain or generalized, then I think centromedian. But only the anterior nucleus has been proven by a large randomized trial so far.
Okay, so sorry, there is the last question, sorry for this, and it is telling us, is asking if there's any experience with RNS or DVS in children with focal seizures.
Oh, yes, yeah. So VNS in the United States is approved down to age 4, I think, maybe 2. RNS and DBS are age 18 and higher, but they both have been used in children, and there's literature in that. That's what we call off-label without approval, but gosh, the way we use most of the drugs in children is off-label. So if there's a clinical reason to do it, it still gets done. Sometimes insurance doesn't pay for off-label use, but there's no reason to think that DBS, RNS, or VNS are or would be any less effective in children than they are in adults.
Actually, it could be the opposite because of plasticity, maybe.
Possible. Yeah.
All right. Thank you so much again for your great talk. We thank also to our audience for attending to this brilliant talk, and we welcome you next for the next webinar that is going to happen in February. Thanks again, Professor Fisher, and thank you, everybody. Have a nice day.
Thank you for inviting.
Bye-bye. Thank you.